Science. So let's get on with it. The reason I'm up on the rostrum is for me to concentrate. There's no other reason. Don't worry. You can stop me whenever you like. And I'm mainly interested in neuroscience, although I'm a psychiatrist. We can talk about anything for that matter. If there's anything of interest to you, please don't be shy. Why are we interested in CBT, the cognitive behavioral therapy? There's of course the treatment aspect, but let's take a look at the 8-week data. It seems that pharmacotherapy is a bit more superior. What's shown in blue is CBT. We see after 8 weeks, or at 8 weeks, 50% is the response rate to antidepressant treatment. But at week 16, it seems that both of these results are the same. I mean, if your patient receives CBT and an SSRI for a period of 16 weeks, I mean either CBT or SSRI, I'm saying SSRIs, although tricyclics are more effective, it seems that the CBT group responds just as much as the CBT group. What draws our attention is not merely this sort of data, it's actually the second part. Let's say there's this improvement in week 16 and we follow them up. One group receives drugs, the other group receives placebo, and meanwhile we're following the CBT group without administering anything else. Let's take a look at the placebo group. They deteriorate very rapidly. That's what we expect. There are those who keep on taking the medication. Now let's take a look at them. I think that the data here are a bit high, but at month 12, 40% of them deteriorate, although they take medication. Let's take a look at CBT group. That's 70%. If we can find the difference of mechanism, we can aid 10% of those patients in the long term. It seems that CBT in the long run may cause more of a difference, may result in more of a difference, but once you stop the medications, there is a quicker deterioration. I don't agree with it per se, I mean on a 100% basis, and I believe that in time the brain changes in depression patients. Even if you stop medication, they can continue feeling good for a while, but of course this is an important piece of data, and it's not the only data out there. In the long run, it seems that the case is different with CBT. Okay, that's important to have 10% more. We give various medications, antidepressants. I will mainly focus on depression because that's my field of interest. Psychotherapy, but also placebo works. I mean, at the first week and the second week, placebo works. In 30% of the patients, placebo works, but it works. I mean, giving placebo causes a difference, causes a change. Does it have any reflections on the brain, though? Can we observe it in the brain? I believe that everything starts and ends in the brain. Of course, there are the syndromes of the disease. These are important, but many things change in the brain. This is a Mayberg study. Can we change the focus? I mean, I cannot see this very clearly. I don't know about you, but if we could clarify, just focus more in maybe. It can be placebo, okay, thank you, or no placebo, or active drug. We see changes in similar brain areas. For example, the subgenual cingulate cortex, just in front of corpus callosum. They can respond to placebo or the active medicine. In both of these groups, we see a change in this site, in this area. So this is one of the key one of the key sites for us. Secondly, there is less change in the dorsal or prefrontal area, prefrontal side. But those who take medication have a higher blood flow. Red is blood flow, yellow is diminishing blood flow. In caudate, we see a little bit reduction. We don't see it above. And here, the hippocampus amygdala complex shows reduction in blood flow in antidepressant patients, but not in placebo group. Which means to say that if placebo works, it works because it changes the blood flow. It the cingulate subgenual cortex. Okay, so how can we measure these changes? We have a few instruments. I don't know to what extent you're experienced. I've just put these to show, maybe I thought that maybe there could be among us some who are not experienced. There's MRI and there's functional MRI or spectroscopic MRI, helping to observe differences in the functions. fMRI, for those who are not knowledgeable about that, gives us the changes in the blood flow, and structural MR shows us the extent of change, how many cubic meters. The other one is PECT or SPECT. We can see PET everywhere in Turkey now, but in the beginning of 1980s it was developed, and the lady inside is Neuro-biological. She is the woman who changed our approach to addiction. If you want to do such a research, you do your research, you come to our SOCAT team, and we analyze these data for you. As far as I know, we're the only neuroimaging team that has sustained in Turkey. So if you would like to embark on such a research, we'd be delighted to help you. I was thinking that would be more crowded. That's why you see such ads. Okay, is brain really so much plastic? Does it really respond to so much change? Or does it change so much? We have noticed in our group that we didn't really focus on the effect of training, but then we came to realize that training has a huge effect, and we tried to identify how much education changes per year. This is hippocampus, that's the frontal area. The more education you get, the bigger this anterior part of the hippocampus gets, and the correlation is quite high because it's 0.001. There could be those with little hippocampus receiving a great deal of education, and vice versa, but generally speaking there is a serious correlation, which means even the education you get changes your brain. In this case, CBT may maybe change the brain. That's the question then. Long-term formal education, of course, has an effect. How about short-term training? This is a very nice study from Germany, and previously some other, I've used this in some other speeches. These are third class students who take an exam. Before that, there's an MR, and then they take an MR after 3 months of intensive work once they take the exam, and 3 months later, when they're on a vacation, we take another MR. And what we see is at the parietal, posterior and anterior sites, there is an increase in gray matter, and also in the hippocampus. So 3 months of extensive studying increases gray matter in 2 sites in the brain. This is observable. After 3 months of holiday, we said they go on to a holiday, and we interestingly see there's no change in the parietal side. Whatever change has taken place continues. But even when the children are on a holiday, the change on the hippocampus continues, which means that change is processed over a long period of time. This seems to be evidence. I remember, and information is processed in a long period of time. I remember from School of Medicine, once your stage is over, after a few months, you realize that you really understand it now. We say in Turkish, we digest the information. So some sort of information we know, we've learned, become more easy to comprehend, which means that some parts of the brain may change by extensive education and training. Sometimes you don't need just as much for you to change, to observe changes in the brain. This is a 2-week mirror reading method. You try to read as if these letters are written on the mirror. For the first week you develop the method, and the second week you get quicker in reading these texts that are reflected on the mirror. The green areas are those which are active, and at the end of the second week we observe a very intensive increase in the blood flow at second week, and right next to it there's the gray matter which increases. So in a 2-week very challenging method, you can observe a little change in the brain. That was very interesting for me. It's a very interesting finding, even the way you change how you change the way you read. In the area that changes, the gray matter, there is no change in the blood flow, but right next to it is a change in the blood flow in the adjacent sides, which means that gray matter increase is not always parallel with the change in function or blood flow. A change in one side can make a change on the other side. So a structural change in a site, in a region, can change the region just adjacent to it. So in cognitive treatment therapies or in other therapies, it doesn't have to be just limited to the region you work on. It can have an effect on the other sites, on the other regions. Looking now at depression. Depression is a complex syndrome, and when you scan depressive people's brains, this is PET, this is a PET view, PET image, be it a Parkinsonian patient or a primary depression patient, certain sites in the brain change in a parallel manner. One is the dorsal frontal cortex and the other one is cingulate cortex. Be it a Parkinson's patient or a primary patient or an MS patient, if the mood disorder is as severe as depression, you show signs of depression, the changes in your brain are parallel, no matter what the underlying disease may be. When you read classical literature, classical textbook, there could be among us those who do not merely read classical textbook. It always says that brains of the depressive patients, dorsolateral regions, especially the cognitive regions, have reduced blood flow. Now this is generally accepted because if you want to be backed or want to find positive findings, you get the most severe cases. You select the most severe cases. Now Mayberg, look at Mayberg. This is not such. These are the veteran. This is the veteran hospital in the U.S. and the others are the Toronto patients. The Hamilton scores are not different, but in the veterans hospital, they're either back from the war or they've abused substance. I don't mean dependent, but let's say that an American drinks 20 bottles of beer per week and they have the least medical coverage. If you take these patients, you see that the prefrontal and dorsal areas do not function so well. I will explain why. But if you take a look at the Toronto patients, imagine this. The patient opens the newspaper, feels bad, and sees that a woman's making a research, that's Helen Mayberg, and she decides, why don't I go take the scanner? And we see just the opposite thing, activation in those sites of the brain. So there is a difference in both of these, in either of these groups. So why is there a difference? we use certain paradigms to measure brain activities in healthy individuals. First of all, in this exercise, we tell a bad event, and we want them to suppress the negative burden, the negative thoughts, and we try to see which sites are activated. We see these are the activated areas. I mean, in order to suppress a negative thought, you activate these same areas. If that's a healthy person and wants to suppress negative thoughts and deal with them, the site where the major depressives are hypoactive, and for other DSM-4 patients, hyperactive areas are activated, which means that at least in the beginning of the disease, in the first stresses, the brain systems, in the first episodes, the brain systems try to compensate for it. But in time, compensation falls, is lost, and probably the limbic system becomes more active in time. I will talk about this. So in the first episode depression patients and the later episode depression patients are not the same. As I will mention in a few moments, in the first episodes, the patient's brains show resistance to treatment. That's the wrong way, though. I could say resistance to disease can be affected by CBT, and these are parallel with what we aim to do with CBT. I mean, at earlier ages of depression, we try to activate more, increase some brain systems in these patients through CBT, but in long run, these systems either collapse or become non-functional. If you ask psychologists about depression, they would say some parts of the brain do not function as well. But this is not how we think. We think this is a circuit, and we think that there are different circuits in the brain that cause different symptoms. Because the brain, if you simply divide it into compartments, that's not the way to approach it. I mean, site A doesn't account for job A. A sometimes accounts for A, B, or C, tasks A, B, or C. But for site A to be able to function in task A, site B has to function in site B. So there's a serious combination in place. Let's take a look at the circuits that cause depression. We see that a series of circuits, that's the limbic system, for example. We're going to talk about amygdala, INS, and the medial frontal cortex, MOF. We see these areas are hyperactive, or active because they're hypoactive. These are usually reward mechanisms or threat emotion mechanisms. By the way, something about emotion, because when we say emotion, we usually understand mood. However, in psychology literature, emotion has got to do with reward and punishment. We don't always accept reward and emotion as the same. We have a wider scope of emotion as we're following the literature. One needs to be careful of that. But there are some other regions. For example, a person looks at the mirror and looks in the mirror, and some parts become active or hypoactive. And in fact, depression is a negative or a positive self-image, and these circuits probably do not function well in that case.
So therefore, depression is more than one circuit going wrong at the same time, breaking down at the same time, or one breaking down and others trying to compensate for it, which they cannot keep up for a long time, and that's the disease that emerges. Whether it be placebo or antidepressant, the subclavian ungulate's cortex activity is reduced. If patients are not responding to ADs or BTs, then we don't see any change in activity in this area. At the same time, in dorsolateral prefrontal area, there is an increase in activation. This does not matter whether it be fluoxetine or placebo or 18 weeks or not primary depression patient, but Parkinson patient, if we see a reduction in depressive syndrome in patient, there's also a reduction in blood flow in that area. That's why Helen Mayberg and her team put the electrodes in the white matter in this area. Now, this area, this diffusion tends form this network. When you look at this network, particularly amygdala and nucleus accumbens, these two are related. Therefore, this region has to do with reward and fear systems. They seem to be mutually related. I'll talk about what that's good for. The cingulate cortex is most interesting, and it encompasses many data, many functions rather. Why it's so important? Imagine the front part is the latest part. The cortical structures formed by the most advanced stage of evolution, the most advanced cortical functions. Underneath was the first limbic structures that were formed in the early evolutionary period. The bridge area is the most strategic area there, just like Turkey's situation, always very strategic. Now, if patients in the anterior cingulate cortex and its dorsolateral area, there's hyperactivity. If there's more blood flow here, they respond well to treatment. But if this area is not working well, then they're not good responders. This area, subcutaneous area, is right on top of it. The interesting thing is that this has to do with the cognitive processes. It's a predictor of whether or not there will be good response to treatment. Blood flow here, higher the increase, the less it is in the subcutaneal area. Subcutaneal mi diyor, ne diyor?
Evet, öyle diyor.
We can think it like this. The more active the cognitive system, the less you use your emotional system, it means. But contrary to depression, this is a lot more active, so the upper part is less active. And the more active the upper part is, the antidepressant or BTD will be receiving a better response. Is there any confusion, or have I made myself clear? Sorry, can't hear this. It's not speaking into a microphone. 6 weeks fluoxetine.
Cognitive behavioral treatment.
Patient treated, comes 1 year later in terms of medication, and we see no, not as far as I'm aware, because it's impossible to follow a patient that long. These are PET images, so we see the metabolism, the neuron metabolism, but these are resting state PET images. 2 important things here. One, anterior cingulate cortex approximately divided into 2 with regard to functionality. Upper part has to do with cognition. For instance, it's related with our awareness of whether or not we have made an error. And the lower part has to do with the control of the limbic system, and in general, their metabolism are in conflict. When one overworks, the one underworks. In depression, subcutaneal works more. On the other hand, if the upper part is working well, they respond well to antidepressants or CBTs. What does this part have to do? The limbic system, especially amygdala, nucleus accumbens, and insula. But the network today has to do with the amygdala system. Now, a more interesting finding: if the frontal part of the brain, frontal system of the brain, and amygdala are working parallel, then the person becomes more hopeful about the future. These are healthy individuals, not depressive, but the worse the system works, the less parallel they are, that is, in their operations, the more pessimistic they become, which means if your amygdala and your frontal cingulate cortex, orbitofrontal cortex included, if these work in parallel, if they control one another, then you are more optimistic about the future. The less they cooperate with one another, the more negative you are about the future. It does not matter one works well and the other one doesn't. What matters is how much of a regular relationship, dynamic causal modeling. If in the upper part it's good, it's a mathematical parameter, then you become more optimistic. The less coordinated these two systems are, the more pessimistic you become about the future. Now, this is a thesis by Burchak. When we look at depression patients, in the first episodes of depressive patients, their amygdala is somewhat larger, we noticed. And this size, interestingly, in the control group, in the medial orbitofrontal cortex, it's positive. In lateral orbitofrontal cortex, it was negatively related. Now, with regard to anatomical information, a reminder, this is corpus callosum and anterior cingulate cortex. In the lower part, there is the orbitofrontal cortex subcutaneal cingulate. Here, this is the dorsal anterior cingulate, and this is the orbitofrontal cortex. Orbitofrontal cortex, the medial side, was positively related with the amygdala in the controls, which is the case with optimism as well. But the lateral one is in a negative correlation. When you look at depression patients, in depressive patients, the laterals are positive and the anterior cingulate is negative. In depressive patients, the relationship had been inverted. The difference between lateral and medial, I will talk about it, but before that, let's concentrate on the amygdala. Hakan talked about this, but what good is amygdala? Now, the most important function of amygdala is conditioning. Maybe more importantly, it ensures that we remain alive. In order for us to understand a stimulant, we need 120 milliseconds, but it's a long period for survival because the threat is there earlier. But if we cannot really, sometimes we need to go into action before understanding. For instance, we saw a snake. We go to thalamus to the amygdala. It takes 30, 40 milliseconds. Now, amygdala, the only thing it has to perceive is the stimulus. Is it dangerous or not? Doesn't matter if it's a snake. Is it dangerous or not? If it's dangerous, reflexes will be triggered and will jump back. It's just like breaking the steering wheel as we're driving, or like we duck when a ball comes. But what happens later on? This stimulus, once the amygdala processes it, after 40 to 60 milliseconds, associated areas also are processed. They attribute meaning to it and send it to orbitofrontal cortex, and he says, yes, I understand what the stimulus is. It's a snake, continue to flee. Or no, this is a branch, a twig, something unimportant. So let's suppress amygdala activity. So therefore, amygdala is ready for active anytime. And through conditioning, it doesn't matter what the stimulus is. Is it dangerous or not? 1 or 0. That's how it operates. And even more importantly, the stimulus, even if it comes from the outer area, it perceives it. While looking at you, amygdala becomes aware of a ball that is thrown this way because it's in the peripheral visual area. Again, it receives all information directly, not through a filtering system. So amygdala is impacted by stimulus. So what does this mean in depression? This is an old study, but it's one of my favorites. So, by Schlein, depressive patients, a negative stimulus is shown, and then a neutral stimulus is given, and 40 milliseconds. So it's impossible for an individual to become aware of this on a conscious level. When you look at it, the amygdalas of depressive patients become more active, especially compared with the control group, but with the use of antidepressants, these hyperactive amygdala, the activity gets reduced. So today's antidepressants, the most important function they do is to reduce hyperactivation of the amygdala. So instead of constantly, this prevents the amygdala from perceiving in a negative manner everything around us. So cognitively, one of the most important signs of depression is that every stimulus is perceived in a negative manner, the most important reason for which is a hyperactive amygdala. And really, the more active this area is, the higher are the Hamilton scores. Again, in all clinical trials, ADs inhibit amygdala, and if you take a group of depression patients and in them the amygdala has been made hypoactive, so clinically you enter into remission a short period of time. So why is amygdala so important? Amygdala is a very important core, and approximately it is connected to everywhere in the brain. For instance, hypothalamus. So therefore, if you have a hyperactive amygdala, your HPA axis is more active. It creates anxiety, reduces insomnia, increases insomnia, reduces appetite, reduces sexual desire, social shyness, analgesic activity. I'm sorry, the speaker is way too fast, sorry. And then you get gastric signs, facial nerves are activated, that feeling of collapse, the facial expression, that makes the patient look older and more depressive. The basolateral nucleus stops searching and spontaneous movements. So all signs of depression are ensured with the connections, through the connections of the amygdala. Amygdala perceives everything in a negative manner, but is there a way to stop this? The system is the medial orbitofrontal cortex. Again, in depressive patients, what you realize is the serious gray matter loss in those areas, and especially in depressive episodes, the more they have, the more gray matter loss there is. The gray matter on the medial side, or functional loss. Why is this important? Now, a group of Caltech students have been taken, and they are told to come hungry, we'll give you chocolate and put you on fMRI, they were told, and the students came. So they were given 1 chocolate, then 2, then 3, then 4. And after half an hour, 1 hour, the brain function started to change. First of all, on the medial side was activated. The activity on the medial side started to shift towards the lateral, so therefore a stimulus that was very attractive while the person was hungry started to lose its attraction after a while. And more interestingly, if a stimulus is a reward, the medial side is activated. But if something has no value for us, or if we have to get rid of it, if you cannot stand the sight of chocolate anymore, then the lateral side activates. Why lateral side? Because the lateral part says there's a danger, change of place, flee, it says. And it also tries to change our behavior. And if the lateral side of a person is damaged, then changing behavior becomes very difficult. On the other hand, when we look at depressive patients, they keep having enumerations, they keep talking about the same things. I say this, the university system area, because we have this rotation coming up, we all talk about that, because our orbitofrontal cortex is activated. Why? Because yuck is dangerous for us, we want to flee it, but we can't. But this is the university system area for me. On the other hand, here's what it tells us. This is a dangerous stimulus. Change this, or change this behavior, or flee. So it recommends change. On the other hand, the medial side decides whether or not it's a reward. If it's a reward, it tells the amygdala, stop, okay, you don't need to work anymore. But if it's not a reward, it tells the amygdala, okay, be active at the same time. So it's important for these systems to work regularly, but unfortunately in this area there's problem in gray matter and depression. Now, let's put it like this now. I don't want to bore you much longer, but venlafaxine or cognitive behavioral therapy or BDT receiving patients, let's look at what has happened to them. Now, whether it be venlafaxine or CBT, to one side, the activity on the orbital frontal cortex is reduced. You don't feel like there's a threat anymore, or they don't feel like they have to change behavior, or remunerations, they don't feel they need to change this. There's a bit on the lateral side here, but when you look at it, we see something very interesting, which is in venlafaxine. Just like I showed you just now in the subgenial area, blood flow must be reduced during any response. We see that reduction, but in patients receiving CBT, on the contrary, activation in this area increases, which means if an agent you have is inhibiting the amygdala, the region that needs to take it under control no longer needs to be active, so this system starts shutting down. However, when you apply CBT, in fact, you overload the system that needs to control the amygdala, and you suppress the amygdala and normalize its function. Now remember at the outset, if your depression patients can activate this system, if they have the skills to do so, you can do this. If the engine of your car does not allow 120 kilometers per hour, then you have to find some other means of accelerating the engine. Now, who will be a good responder to CBT? At the outset, look here, look at this part. Hypoactive subgenial area, those who are hypoactive at the outset, they respond better to treatment. Amygdala is active anyway. So the real problem here is the hypoactive subgenial area should be activated through CBT during depression, and it's possible to do this with the cognitive scheme.
If patients at first cannot undertake negative emotions, that they cannot take negative emotions or activate these areas, these patients respond poorly. This is everything I've just said. This is stimulus about the self. Amygdala is hyperactive if the person is tending towards depression, but it can also be lifted through CBT or antidepressants. On the other side, we see cognitive functions lower before treatment and increased after treatment. So how is this done? We don't really know how we do this. What happens with CBT that changes the brain? We don't know that. But as a result, as a conclusion, we know that the most important area, the subgenial area, is controlled by certain systems, and they change the activity of the subgenial area. And deep brain stimulation is in fact working on this intermediary key system. So there's a depressive, hyperactive amygdala and hypoactive dorsolateral prefrontal cortex, cingulate cortex. If you give CBT, this system starts activating, which means there is a reduction in the activity of amygdala. Or if you administer solely antidepressants, amygdala becomes less active, and after a while the prefrontal cortex becomes normally active. I've just said that long-term antidepressant use in depressive patients won't give very bad results, because at least it takes the pressure from the prefrontal system, it seems. This is the 2000 study with GATA, the Medical Academy. Here we see obsessive-compulsive patients change the blood flow in their brains. We identified with CBT dorsolateral prefrontal area, as in the case of depression, has increased perfusion, but in the caudate and putamen we see a reduction in the blood flow in the brain. Almost in all OCD cases, it could be medication work or CBT work, without any reduction in the blood flow in the caudate, there is no improvement or remission, and the adjacent subthalamic nucleus does a brain stimulation, and this is a method that's tried seriously in the US. If we can solve the social insurance agency problems, I guess we can do this at our schools. Finally, I'd like to finish by talking about a study of the previous year. This is an Israeli group. They activate an immune system in the brain shortly by vaccination to prevent depression. I don't know whether this will continue, if it does, it seems that we will be working on vaccines. Thank you for your attention.